Thank you, Sylvia. It's my pleasure to introduce my Australian colleague, Harry Raju, who sounds English but works with us in Australia, which is very lucky for us. And he's going to speak on pauses and heart blocks when he's too slow. Thanks, Harry.
Thanks a lot. So, bradycardia and AV block is a recognized manifestation of the physiologic adaptation of training. And there are two primary competing hypotheses for the mechanism of this. And historically, most doctors have thought that this is because athletes have an increase in their vagal tone. But actually, careful and objective analysis of the actual data to support this suggests that the true mechanism is likely predominantly related to ion channel remodeling, including HCN4 or the funny current, which is dynamic and reversible and likely related to microRNA involvement. Unfortunately, I don't have time to go through all the evidence, but it is important to recognize that high vagal tone is probably a misnomer in athletes. And this is evidenced by multiple cohort and observational studies in veteran or lifelong endurance athletes, and whether you look at cyclists, cross-country skiers, or other masters athletes, there's plenty of data that suggests that those individuals who train more and at a higher level have more bradycardia, more conduction system disease, and more sinus arrest. And I think it's fair to summarize this in the greater lifetime dose of endurance training, the more bradycardic implications you accumulate through your lifetime. So this is the commonest manifestation, and that is sinus bradycardia, which we will see in both young and older athletes, and it's often associated with first-degree AV block or prolongation of the PR interval. And the international consensus, now several years old, recognized this, that sinus bradycardia is a normal phenomenon, and PR intervals of up to 400 milliseconds are also accepted as normal. And although lower sinus rates below 30 beats per minute and PR prolongation beyond 400 can be normal, they are reasonable thresholds because of how infrequent this is for further evaluation. One of the other manifestations that you will commonly see in athletes of sinus bradycardia is a junctional rhythm and so-called functional AV dissociation. And you'll see the transition on this ECG from normal conduction of sinus rhythm on the left through a junctional rhythm with varying PR and P and QRS association before restoration as sinus rhythm restores towards the end. And although this is AV dissociation, it is not AV block, and so therefore requires no therapy and is completely benign. I'm going to step sideways into the ESC guidelines for pacing, which again are now a few years old, but I was happy to see that this finally recognizes that sinus node disease is an indication for pacing, even in the general population, only when bradycardia due to sinus node disease is symptomatic, and that symptom rhythm correlation is a crucial step in decision making. And although there is a class 2B caveat where individuals with syncope who have asymptomatic sinus arrest that exceeds 6 seconds can be a reasonable indication for pacing, that's a class of evidence C and 2B. In general, sinus node disease, sinus bradycardia, they have no prognostic relevance for individuals, and so the benefit for athletes' patients is in improvement in their symptoms, and hence symptoms are key. Whereas AV block is a little bit different, and we worry about prognostic implications. And true infranodal disease, so that's true Mobitz 2 AV block, and most of complete heart block, irrespective of symptoms, do have prognostic implications. And that is the potential for asystole with a small risk of cardiac arrest. I would like to put my own little caveat into this, that to beware of the pseudo-Mobitz 2 AV block, and I'll come on to what that is, and also remind you that pathologic AV block is caused by an underlying disease process, and particularly in the younger individuals, it is important to try and establish what that disease process is in case it might be treatable. And this guideline, again, although primarily indicated for the general population, acknowledges that in asymptomatic individuals, there should be a distinction made between the benign nodal level of AV block and the more pathologic, or the pathologic infranodal AV block, and particularly in the lower degrees, so first degree and second degree AV block. So I'm going to illustrate this with a couple of case examples. So this is a 49-year-old veteran triathlete on their resting ECG, shows sinus bradycardia in first degree AV block, very common, physiologic adaptation, and an ambulatory ECG that shows what at first glance may be interpreted as Mobitz 2 second degree AV block with a single non-conducted P wave and 2 consecutive non-conducted P waves, which is advanced second degree AV block. But when you interrogate the PP intervals or the sinus rate, you will see prolongation of the PP interval as you approach AV block and shortening again thereafter with restoration of one-to-one AV conduction. So that is, as you get more sinus bradycardia, you get more AV block and the reverse. This is nodal level behavior and is benign. An interpretation in this individual of that advanced second degree shows the same phenomena. So this is pseudo Mobitz 2 AV block. It is not true Mobitz 2, which requires a fixed PP interval. This individual is asymptomatic. They have nodal level AV block. They can be reassured this is a normal phenomenon. This is a slightly more difficult case in a younger athlete where the level of concern is often higher in AV block, but again an endurance athlete, and I'll hope you'll all see that this shows resting 2-to-1 AV block with a sinus rate of 80 beats per minute, which is fairly unusual. Having said that, with some straight leg raises, which is why you have this wandering baseline, you show improvement of that 2-to-1 to 3-to-2 and then 5-to-4 AV Wenke back conduction, and thereafter 1-to-1 AV conduction with a normal PR interval. Because of how unusual this behavior is, and particularly in a young individual, this further evaluation with obviously imaging, Holter monitoring, and exercise provocation showed periods of first degree AV Wenke back 2-to-1 throughout, bouncing between one to the other. And these are all features of nodal level AV block. So where you have periods usually of sinus bradycardia, but at the very least relative sinus bradycardia with changes from first degree to AV Wenke back, and an increase in your sinus rate resulting in improvement in the AV conduction. This is all consistent with extrinsic basal physiologic, and so this again is all consistent at this point in time of nodal level AV block in an asymptomatic individual. And I put reassure, this is unusual, and we know that ion channel there is a genetic predisposition to this kind of behavior, but at this point in time it does not require intervention, but should probably be maintained under surveillance. I just have a few final slides to remind you of what we've gone through. The most important thing when we're talking about any kind of bradycardia is where is the disease? And the lower the level of disease in the conduction system, the higher the level of concern because of the potential for prognostic implications in His-Purkinje disease. And although I haven't had time to show you any case examples, it is very unusual that you actually require an invasive EP study to make this determination, although in some asymptomatic young individuals it may be necessary, and we can measure the HV interval, which is a representation of true distal conduction system disease, but that is very unusual in the athletic population. And remember that actually those intervals can be slightly prolonged in most athletes in any case. And when approached with an athlete, those who are asymptomatic, where the bradycardia, whether it's AV block or sinus bradycardia, improves with exercise and increasing sinus rate, and probably where it resolves with detraining, if that's a consideration, those individuals can generally be reassured, at least for now, and then maintained under surveillance, whereas therapy is often, particularly in the veteran athletes, indicated for relief of symptoms, true compelling distal His-Purkinje or infranodal disease, remembering that there are genetic causes and myocardial disease that can result in AV conduction, as well as some systemic diseases, historically always Lyme, and in more recent years COVID myocarditis, and that bradycardias are associated with lifetime risk of atrial fibrillation. Again, I haven't been able to go through that data. So to summarize, there is no such thing as too slow for physiologic adaptation, but reasonable thresholds are sinus rates of under 30, PR intervals markedly prolonged at 400. Every case should be interrogated, the presence of symptoms and what you're trying to achieve by therapy, and is there any compelling infranodal block? Diagnostic provocation is really helpful. You can do that by straight leg raising, posture changes, Valsalva, formal exercise provocation, pharmacologic provocation, usually in the EP lab with atropine or isoprenaline, detraining, and very, very rarely an invasive EP study. And remind individuals that even if their bradycardia and AV block is physiologic adaptation, they are at risk of chronic bradycardia, some of which may become irreversible in their lifetime, and meaning they may require pacing for symptom relief, and that their lifetime risk of AF is increased thereafter. Thank you very much.
Question up the back, Andre Lagush.
Harry, up here.
Oh, yeah.
Simple, complex, and brilliant as always. I was just wondering, I wanted to raise my own experience with the recommendations for symptomatic sinus node dysfunction and sort of a 2B recommendation for pacing. My experience is with what I call chronotropic reluctance. You know, often the masters athlete comes in and their maximum heart rate is 120, 130, and often going along with not feeling as great as they used to. I don't know what that ever means in a masters athlete. And my previous enthusiasm or attempts at pacing, because it makes sense, give them an extra 30. And I would now conclude that it never, rarely say that, never works. And so I would put a damp cloth on the idea of, because what you get in terms of extra heartbeats is completely taken away by the complete failure of pacemakers to even vaguely approximate what is physiologically required in terms of the beautiful sort of management of heart rates, ups and downs in daily life.
So yeah, I completely agree. And obviously remember that pacing devices are not intended for masters athletes. They're intended for normal daily life. And so programming pacemakers to overcome chronotropic incompetence in a masters athlete is really hard. If you are going to do it, I would suggest, unfortunately, there's only one company that has a CLS algorithm, which should approximate physiology better than the more conventional mechanical sensors, which are based on motion. But even in that situation, it is very difficult to overcome if the only issue is chronotropic incompetence and not syncope or pre-syncope or something else.
I don't need the microphone because my very good friend stole my comment.
No other questions? Okay, we will now move to the quiz if the panel members can come up.